We're live, Mr. Chairman.
Thank you. Good morning, everyone, and welcome to the briefing of the Public Safety, Transportation, and Environment Subcommittee. My name is Mcrae. I'm the Senator for the 45th Legislative District and Subcommittee Chairman for PSTE. Today, we'll be joined by a number of leaders and organizations doing important work around communities concerning violence prevention within our neighborhoods. It goes without saying that for decades, our country supported failed policies of increasing the numbers of incarcerated while adversely removing the federal and state dollars that contributed to community programs and upliftment of our community. Over the past decade, we have seen a course correction in legislative bills such as the Justice Reinvestment Act, which overwhelmingly had bipartisan support, and programs such as Safe Streets and ROCA that blazed the trail with violence intervention. Last session, this chamber overwhelmingly voted for Senate Bill 708, sponsored by Senator Carter, and that bill passed our chamber by a margin of 42-4, expressing our commitment to violence prevention in the state of Maryland. Our goal today is to learn about the work that's happening around violence prevention and have a stimulating dialogue on possible solutions on moving forward. Before we hear from the speakers today, I would definitely like to recognize my committee members, Senator Doug Peters, Senator George Edwards, and I'm sure that we'll be joined by President Emeritus Senator Mike Miller. I would also like to thank the staff who's done a good job helping me navigate today, Matt Bennett and Kim Landry, for helping to facilitate this meeting. At this moment, I'd just like to call up our first speaker, Gregory Jackson Jr., co-chair of Maryland Violence Prevention Coalition, National Advocacy Director, Community Justice Action Fund.
All right, thank you for having me. First of all, thank you to Senator Chairman Mcrae, Vice Chair, Senator Miller, and anyone else who has been strong advocates for the efforts to end gun violence here in the state of Maryland. Again, I'm Gregory Jackson. I come to this work not because I love it, not because I'm excited about it, because it's necessary. In 2013, I became a survivor of gun violence and learned firsthand how serious this trauma is. In America, over 100,000 people are shot or killed by guns every year, and every 15 minutes we lose another person to homicide. And when we look at homicide, those folks are overwhelmingly Black or brown. And not only is it an issue that has become this public health crisis in numbers, it's now become the #1 cause of death for Black men under the age of 44, the #1 cause of death for Black women under the age of 19, and something that's impacted far too many in these really trying times. So I just want to thank you all for just acknowledging and taking this time out to explore solutions around this very critical issue. Maryland has frankly been a pioneer and a front runner when it comes to investing in proactive solutions to address gun violence. Maryland was one of the first states to pull forward with the violence intervention and prevention funding, and really became someone who trailblazed resources that have led to so many lives being saved, not only in the state, but in other states who have jumped in line. States like Virginia, New Jersey, New York, California, and now even Texas are starting to invest in violence intervention and prevention programs after Maryland has jumped in the boat. And the reason they're doing it is not because it's just the right thing to do, but they're seeing real results. The programs that we're advocating for have reduced gun violence significantly where they've been adequately funded and invested in. In Maryland, I'm sure you'll hear from some of the other speakers today about the efficacy they've seen in certain neighborhoods, but cities that have adopted this at a citywide level and states that have really invested in this have seen upwards of 30 to 40% reduction in gun violence in their community by purely giving adequate investments for these types of programs. But we recognize this is a very tough time with COVID-19 and with the resources and the challenges around our economic shutdown. We know that budget movement and investments are very challenging, but I want to just iterate to you that the folks who are doing these violence intervention and prevention programs have also now become very essential in the response to COVID-19. The neighborhoods that they're working in, the communities they're working in, they're now doing double duty. They're trying to help keep folks safe, but also not just from gun violence, but also from the COVID-19 crisis. And a lot of the root causes of gun violence in our communities are now intensified with the presence of COVID-19. So when we think about housing instability, economic challenges, trauma, conflict, and frankly, the fact that everyone is not safe in their home reinforces the importance and the value of investing in these programs to keep folks safe in a COVID-19 pandemic that unfortunately is making things way dangerous for too many of our folks. When we talk about investing, I think I spoke of this a little bit earlier, that we're advocating for programs that work. Today, you're going to hear from evidence-based strategies that have had the academic support and research and have shown significant impact. We're not asking for just general investment in the community. We're asking for you to invest in programs that prioritize the most at risk and provide therapeutic, traumatic, health services, legal services, et cetera, to make sure that the folks who are most at risk of being a victim or a potential offender of gun violence are being serviced to help reduce gun violence here in the state. These programs look very different. You'll hear from folks who are doing work in survivor support services. An overwhelming number, I believe it's 72% of people who commit a violent offense were once a survivor first, just like me. And we found that when you invest in their recovery in an effective and empathetic way, with real services behind it, you can drastically reduce gun violence. You'll hear from programs that apply cognitive behavior therapy approaches, which really focuses on how do we take a therapeutic approach to shifting the mindset of someone who may be going down a rocky road towards violent offense. But you'll also hear about people who are on the front lines every day, dealing with communities that are already dealing with tension or conflict and are de-escalating these issues with real conflict resolution practices and taking things that we most commonly hear about in mental health offices or with your therapist. They're taking those strategies directly into communities to help de-escalate and bring peace directly to the neighborhoods. Not only do these programs work, they're cost effective. And I want to remind folks here that there is a real cost to homicide. There's a real cost to gun violence. We're not just asking for you to invest because it's the right thing to do. It's also fiscally responsible because for every life we save, there's a price tag associated with that. It varies from city to city, but the range of what it costs to deal with a homicide is between $700,000 and $1.4 million in the state of Maryland. And so looking at that big price tag that we already pay when we lose someone to gun violence, I hope that you will look at this as not only a budget allocation, but an investment that will hopefully provide a return and reduce the fiscal responsibility and strain that this gun violence epidemic is impacting us. Lastly, I want to share that, well, two more things, sorry. Before I say the last part is that, you know, we are very clear with the sheer numbers of what's happening with gun violence in our state, that this is a public health crisis and a public health issue. And so we are just asking and advocating that our leaders invest in public health approaches that address the risk behaviors that lead to gun violence and do more than just the crime control carceral approach that we've done for decades. You know, we're not asking to not do that, but we're asking you to prioritize some of the proactive preventative methods that we know have proven true. The last thing I want to share is that we are very clear that research and evaluation is a huge part of this. A lot of these programs are frankly new to some elected officials and to the general public. And so we are strongly advocating for heavy evaluation and investment in research to make sure that the work that's being done is being captured and communicated adequately, and that full cycle of engagement is something that we're all invested in, all understand, and are all advocating for, because these programs do need to grow, some need to refine, and some will evolve with the investment of everyone, not just fiscally, by putting their attention into how these programs are running and how they can be more effective every step of the way. So with that, I want to thank you so much just for a broad intro. You're going to hear from some of the most amazing people who are not only doing really great work, but are very passionate and frankly putting themselves in the line every day to prevent this violence from happening in our communities. But again, thank you to the Senate leadership. Thank you to my co-chair, Liz, and everyone here that will be presenting. With that, I will pass it to Dr. Joseph Richardson.
Before you step in, Dr. Richardson, first I just want to thank you, Director Jackson, for the comments. I want to at least recognize that my chairman has joined us. Chairman Gagazone has joined us, and we also had our subject matter that we crossed with from the House that was invited, and Delegate Mike Mcrae, our friend from Western Maryland, has also joined us. Thank you both, and Dr. Richardson.
Thank you, Greg, for the opening comments. And I would like to thank the senators for inviting me to speak today, and more importantly, for investing in gun violence reduction efforts in the state of Maryland. As a member of the Advisory Council for the Maryland Violence Intervention Prevention Fund, I appreciate the efforts you've made to invest in violence reduction in the state. And so I am also proud to say that as the co-founder of the Capital Region Violence Intervention Program, which is a hospital-based violence intervention program at University of Maryland, Prince George's Hospital. This is also the second HVIP in the state. We received funding through the MDVIPP fund. So could you please advance to the next slide? So our program was started in August of 2017, and I founded it and directed it from August 2017 to June of 2019. And in 2018, we were awarded $527,000 to support our efforts to provide psychosocial services to victims of violent injury who are treated at University of Maryland, Prince George's Hospital Center. Our goals for the HIVP are to reduce rates of trauma recidivism, which is defined as 2 or more hospitalizations for violent injury, and also to reduce the rates of criminal recidivism. One thing that I want to make note of is that up to 65% of all the patients who are treated for violent penetrative injury, that's either a gunshot wound or stab, will return to the hospital within 5 years for a similar injury, and 20% of that population will die as a result of their injuries. So it's critically important that we provide the services to prevent those frequent flyers from coming back to the hospital for repeat violent injury. Next slide. Next slide. These are just the numbers from 2014, just to give you a sense of how many people we actually see per year. And so as you can see, from 2014 to 2018, the numbers fluctuated. But as you can see, in many of the years, the numbers increased for a 5-year average of 746 victims of violent injury a year. But as we know, this year, as a result of COVID, we are seeing spikes in violent injury across the state. But I just want to make you aware of that 746 a year number is roughly 2 people who are coming into the trauma unit every day for violent injury. Next slide. So where we start our process is through our credible messenger, is also known as a violence intervention specialist. This is a picture of Che Bullock, who was also injured and treated at the University of Maryland, Prince George's Hospital Center in 2013, and was actually a member of my study that I conducted from 2013 to 2015 with 25 young Black men who had been violently injured. He happened to be one of the young men in my study who was stabbed 13 times. He ultimately, after the study, I decided to employ him as the violence intervention specialist, and this is where the work starts, at bedside. And so he's meeting with a 16-year-old here who was a victim of a gunshot wound. And this is where we start the process to build trust and get young men and women involved in the process to receive psychosocial services. Next slide. So our approach, we use a trauma-informed care approach where we're more concerned with what happened to the person and how we can begin to address that by providing safety as well as psychosocial support services to address primarily traumatic stress and complex trauma, because what we're finding is many of the young people that come in who are injured have symptoms of traumatic stress that are similar to what you would see in a soldier who was in a theater that was injured in Iraq, Afghanistan, or Syria. And so our challenge is to get young people who are typically distrustful of the criminal justice and the healthcare system involved in cognitive behavioral therapy. We also provide peer mentoring and support, legal assistance with pro bono attorneys who are able to represent our population while they're going through the criminal justice system. And 70% of the violently injured young men that we have coming into the trauma unit are criminal justice involved. We also provide housing, and I asterisk that because that's probably the most difficult resource to provide to our population because of the scarcity of affordable housing. And we do employment and educational assistance as well as conflict resolution. Next slide. And so when we started, our trauma recidivism rate was 32%. I want you to make note of that because that means 1 out of every 3 violently injured patients that came into the hospital at that time, this was their second time of being injured. So we have experienced having a high number of people who are coming into our hospital who have been injured 2 or more times. By January of 2019, we reduced the trauma recidivism rate among our 116 participants to less than 1%. Only 1 person out of the 116 people that we provided services to returned to the hospital. And the only reason I want to make a story, provide you with the story, the only reason why that person came back to the hospital, because at that time they were on the cusp of being evicted. We could not provide them with housing services or emergency housing resources. So they attempted to take their EBT card and sell it to provide the resources, monetary resources to close the gap on what they needed to pay for their rent. And in the process, they were robbed and shot. So it's even in terms of the 1 person that returned, as you can see, was a result of the lack of housing that we have and sometimes the desperate decisions that many of our young men make in order to survive. So 70% of our patient population was involved in the criminal justice system, and we only had 1 person rearrested for a new offense. So as you can see, these programs work in terms of trauma and criminal recidivism. Next slide. And so my lab at the University of Maryland, College Park, the Transformative Research and Applied Violence Intervention Lab, is engaged in this kind of research at both trauma centers in the state of Maryland at the University of Maryland, R. Adams Cowley Shock Trauma Center, as well as University of Maryland, Prince George's Hospital Center. And I conduct and lead studies on gun violence that will inform innovative interventions, as well as determine the impact and effectiveness of the hospital violence intervention programs that we have in the state. So once again, I appreciate your time and thank you.
Thank you, Dr. Richardson. First, I'm just like to ask a question. How are those, I noticed you said 70% were involved in the criminal justice system, but the 30% that wasn't, how are they introduced to your program?
Welcome.
They're introduced, all of the participants are introduced when they're injured at bed. So once they're treated in the trauma center and they're stabilized, then our violence intervention specialist approaches them at bedside. And that's when we start the process of an intake, getting an understanding of who has been injured before, because we like to triage our services. If someone has been injured before, if this is their second or third time being injured, we target our services to that person. And we also look at the victim offender overlap, because what we have found is that many of our young men who are behind the gun at certain points are in front of the gun as well. And so what we're trying to do is ascertain who is involved in the criminal justice system, and then how can we begin to provide services that will reduce their levels of recidivism as well. So we collect data on both their experiences and interactions with the healthcare system as well as with the criminal justice system.
Thank you. Before I recognize the committee to see if they have any questions, we were joined by Chairman over in the House of Delegates of Chair of Public Safety, Delegate Keith Haynes, and we're also joined by Delegate Susie Proctor, and just wanted to say welcome. Is there any questions of any of the members in the committee? You can either put it in the chat or just raise your hand. Perfect. Look like seeing none. I'm going to go to our next speaker. I don't see Mr. James Tipson, but I do see Mr. Omar Maconda. Oh, I see James. Hey, James, please.
Hey, Senator, thank you for the time. Appreciate the opportunity to present to you guys about ROCA. Let me see where we are. Amar, is that the slide deck from yesterday?
Yeah. So JT, let me kick it off, and I'll go to you in a second. So thank you everyone for taking the time to listen to us and explore the importance of BIP programs. We really appreciate it. I wanted to give you a very very brief introduction to what we do and how we do it, and then focus really on the outcomes and the data that support why the fact that this work is having the effect that we want it to have. So can we go to the next slide? Our model is built on three main principles to start off. One is creating very strong relationships with young people. The second is that CBT, cognitive behavioral theory model, that Greg Jackson talked about at the beginning, to really help young people develop emotional regulation. And then the third is giving young people the opportunity to practice that emotional regulation in the context of work or education. That's our model, and we're happy to go into more detail about exactly how that works. But for now, let's focus really on the data. Can we go on to the next slide? So one of the things and can we actually go to the next slide and then we'll come back to this one? One of the things that's really important to recognize with ROCA is that when we start off, we get young men who are at the very highest risk. The vast majority of our referrals come from BPD, parole and probation, and DJS. Those are the partners who refer to us. And we have 182 participants currently. We had 95 in that first year. And 98% of them have a history of arrests. 97% of them are street or gang involved. 92% of them have no employment history. 75% have not graduated high school. About 40% are gunshot victims. So these are referrals coming to us from criminal justice partners that really are super high risk. And it's our role to work with them very intensively over 4 years to try and make some change happen. And what this slide kind of demonstrates, I think, is the effort that it takes to make some of that change happen. When we get a young person, there's a very high degree of mistrust and a very high, these are young people who don't necessarily want to make a change in their lives when they start off at ROCA. So we're making a relentless amount of efforts to engage with them. And so that 13,000 efforts that you see to connect with young men, that's really the start of building a relationship and having them engage in something. 80% of our young men in the first 2 years actually engage in CBT. And when you keep that in the context of who are the young people we're working with, that's a really significant amount. 80% of these young men who are highly criminally involved are actually now engaging in this cognitive behavioral theory work. 83% of them stay in the program. And our current intermediate outcome is that we have demonstrated for those who have stayed in the program for at least 2 years in Baltimore, 70% are demonstrating an increase in emotional regulation, according to our evaluator, and 88% are demonstrating workforce readiness gains. So those are the intermediate outcomes that kind of put us on track for what we want to see in terms of violence and recidivism and a reduction in crime. So with that, I'll let JT take it from there.
Yeah, so quickly, those were year one numbers. So I'm going to give you an update of 2020 because we do actually have 2020 numbers available. So right now we're up to about 182 participants that we've actually served. And that's about an 83%. Out of those 182, there's been about an 83% retention rate, which holds pretty close to last year. Some of the reasons why participants don't stay in the program, the highest reason why they're dismissed from the program is because of reincarceration. But if you remember, we're dealing with a population that's extremely high risk. So when we get them initially, they're so deeply criminally involved that it usually takes a while for us to really be able to crack into that criminal behavior and get them to kind of scale back. So what happens is we'll get a large percentage of those individuals who might get rearrested within a week of us actually getting referred to us, or, you know, a short period of time before them getting referred to us, they might get rearrested. The next highest number was due to death. Since COVID has started, we have lost about 12 young men in the program to homicide. We have had probably about another 15 to 20 that have been shot during that time period. And we're talking about within the 8 or 9 months that we're in COVID now. So overall, we have a 20% of the participants who were dismissed from the program. It was because they were deceased. And so, you know, the reincarceration and the death rate are really big factors into why these young people don't stay connected to the program, obviously. Just a little bit about the age demographic. We serve 16 to 24. Out of that group, the highest number is between 18 and 19. That's about 32% of our actual population. The next number will be between 20 and 21, which is about 30%. On the lower end, the 16 to 17-year-olds, we have about 15%. There's a gap there because there's a gap between the 13, 14, and 15-year-olds to when they get to us at 16. So we realize that there's a need for that younger population to also be served, but about 15% is between the ages of 16 and 17. The other numbers that Amar talked previously about were pretty on par, except for our numbers have actually gone up since COVID. The amount of efforts, we have made about 16,000 efforts this year to reach young people. Successful contacts have been about 8,000, so about 50%. And then we've had about 1,500 young men who have contacted us first. So, you know, it's been a mixed review, but we still have the 80% who are still participating in the CBT and the applied life skills and in those areas. So I'll stop there because I know I'm over time. Thanks, Joyce. If there are any questions, I'm sorry. I had to rush through it.
No problem at all, Mr. Tipson. Just want to first thank you all for your leadership. I know I've been over to your facility several times and appreciate the great work that you all are doing. I'm going to ask, is there any questions of the committee for our friends over at ROCA? Seeing none, I'm going to go to the next presenter. We have Adam Rosenberg, our Executive Director of Lifebridge Health Center for Hope. And I know him in a couple capacities, but he's the for community violence over at the Lifebridge Health Center for Hope. I know him as a pastor, a good friend, and just a leader in the city of Baltimore. Thank you for your leadership, Rashad. And you all can get started, please.
Thank you, Mr. Chairman. Those are very kind words. I appreciate the opportunity to be with all of you this morning here. And thank you for recognizing my colleague, Rashad Singletary, who runs our community violence work. And I just need a tip of the hat to Joyce Lombardi, who helped organize today's hearing there too. At Lifebridge Health, we've taken an expanded approach to what we're doing in the area of violence prevention. Many of you may know me in my previous incarnation as the Executive Director of Baltimore Child Abuse Center. In January 2019, Baltimore Child Abuse Center joined Lifebridge Health as part of our efforts to create a new paradigm when it comes to violence intervention and prevention there. We recognize that most of the kids that we were seeing had been impacted by other areas of violence, their family members, their communities, their neighborhoods, and that it was limiting for us to only be looking at child abuse when we could really be providing a whole degree of help and services for the whole lifespan of violence. And so what Lifebridge Health created with us over the last year is our new Center for Hope. And you're frankly one of the first people to be seeing this new building and this new logo here. We launched it back in November. And the Center for Hope, we believe, is really one of the first programs of its kind in the nation that is taking the best of everything that's out there about what works with hospital violence interventions, what works with children's advocacy centers, what works with family justice centers, what works with domestic violence, and putting it all under one roof, both physically and programmatically there. And we have a mission to advance hope, healing, and resilience for those impacted by trauma, abuse, and violence through a variety of different ways there. And so we aim within our Lifebridge Health footprint in West Baltimore, Northwest Baltimore, Baltimore County, and ultimately stretching out to Carroll County, where Lifebridge Health is, to provide this integrated approach for child abuse, domestic violence, community street violence, our Safe Streets programs, and a fledgling elder abuse program. We know that violence begets violence there, and it is a public health problem, and it's the responsibility of our community to take that role and share the connections where poly-victimization exists there. If you can advance to the next slide, you can see that over the last year, even before we launched this formally as Center for Hope, we provided help for over 4,700 victims of abuse, exploitation, and violence there, through mental health therapy, through forensic interviews, through emergency shelter, through safety planning sessions there. Because each of these points of violence are not independent by themselves. Violent victimization is typically not a one-time event. It's referred to as a recurrent disease there. Victims of violence often experience post-traumatic stress disorders there, and frankly have a constant traumatic stress disorder because once they've experienced the violence, they're still living in spaces of violence there. And these incidents of violence don't just necessarily occur in violent, dense urban neighborhoods there, but we've got communities who live in violence throughout the state there. And much of what we've learned and seen can be replicated as families of violence grow up and live with other episodes of violence there. What we're trying to do is take that same health approach and not do the typical treat and release, but be able to treat and reduce and explore these other causes of violence there. If I can go to the next slide, our new model is really a new model of practice, and taking what's worked with evidence-supported practices throughout the nation and really seeing a better way to change this to make sure that victims of violence aren't coming back there, and that taking all these approaches and combining it into one most effective team there, which also, by the way, combines different forms of funding. I appreciate the support many of you have given us over the years through appropriations and budget and tax to fund this. And these programs are funded both through Victims of Crime Act money, VOCA money, which the governor's office distributes, but as well as the VIP funding that's discussed here, private philanthropy, hospital dollars. And so it's a real lattice work to make sure this works. Next slide. And ultimately, you know, we arrive at this new facility that we aim to open in March of 2022 in Park Heights on Sinai's expanded campus next to the Pimlico track, where we will house all these programs under one roof, collaborating with our police partners, collaborating with our partners from social services as well, to make sure that we're helping them achieve their best results there. That a lot of our work isn't about necessarily removing funding from one organization, but helping organizations do what they do best. That police officers should be able to provide public safety and investigate. Social services should be able to determine if a child, if an adult is safe in that environment, and we can connect them to those wraparound services, to workforce development there, to counseling, to case management, to treatment, to help them escape that cycle of violence there, and really do what we've done very well for 30 years, is build a collaborative approach and move forward there. Let me advance to the next slide before I turn this over to Rashad. Our community violence programs are proven to work there, and very similar to the statistics that Greg and Dr. Richardson shared earlier there, our programs in the community keep people out of being victims of violence again there. And with numbers such as 92% avoid rearrest and 98% avoid readmittance, these programs work. And we really continue to appreciate the ability that you've had to let us do this work and explore and expand it there, so we can keep as many people from being victims of violence from becoming victims of violence again. Let me tip it to Rashad, who can share also about the particularly innovative work we're doing in Safe Streets and our own hospital violence intervention programs as well. Rashad?
Thank you,
slide.
Adam.
Yeah.
Thank you, Adam. Good morning to everyone. To my friend, Chairman Mcrae, to Vice Chair To all of our Senate and House representatives who are on today, thank you so much for this opportunity to engage you in this conversation. For the past 6 years, I've had the tremendous opportunity of serving as a site director for a Safe Streets program in Central Park Heights. Now I'm the community violence program manager for Lifebridge. It's our responsibility to develop programming to shift the culture of violence in West Baltimore and also specifically in the Park Heights corridor. We have our Safe Streets program and our hospital program, and we've integrated the work that both of them do to ensure that we can reduce and hopefully eliminate gun violence within the Park Heights community. Our hospital responders are individuals who are credible messengers from the actual community, who work inside of the hospital, who respond to individuals of gun violence, who come in as first-time offenders or individuals who have repeatedly come in. How do we develop programming to ensure that these individuals do not relapse and fall back into a culture of violence? They have programs within the hospital that assist these individuals to hopefully help them to regain their life back into the community. With our Safe Streets program, our Safe Street program also has individuals who are credible messengers inside of the community who want to reduce retaliation and reduce shootings and homicides in that area. What we've done is develop more programming so that we could assist individuals with sustaining their lives once they come back into the community. One of the things that really affected my life is one of the individuals that we have been working with. The gentleman left out of my office, and maybe 2 hours later, we heard gunshots, and the same young man that I was just helping to do his resume, get him ready to interview, was laying dead in the grass in front of me. And so these individuals are not numbers to us. They are individuals who we believe have an opportunity to really advance in life. But they need exposure and sustainable resources that's going to allow them to curve that trajectory in their lives of violence. And so we are using different approaches, innovative approaches to ensure that we can help assist these individuals in their lives. Also, this week, we've started our Kuji Chagalia job readiness program, where we are building the professional skills and tools of young men and young women within Safe Streets, within our hospital program, to assist them with the tools that they need to obtain and sustain employment. But then once they finish that 5-week course with me directly, then we transfer them to a virtual learning program within the hospital with the hopes of them having an internship in the hospital and obtaining sustainable employment. So that's some of the work that we're doing. I'm thankful to Adam and his vision as it relates to the Center of Hope and how we've been able to really integrate this work and really go on boots on the ground to try to shift the culture of violence in Central Park Heights. So thank you for this opportunity.
And if you could just advance to the next slide. I think it's just demonstrative of the fact of how we've combined our work on the streets with our Safe Streets program there and our community violence programs with what we're doing in a health system there. And so we can then connect people beyond what the traditional mandate of Safe Streets is, or what the traditional mandate of a child advocacy center is that when we recognize there are health implications, or when we recognize that there are much needed other violences going on there, we can connect those families to those outcomes. And probably the most exciting thing we'll be able to share, hopefully in a year or two from now, is being able to actually measure success through tracking what our clients' ACEs are when they come into the program, their adverse childhood experiences, their history of violence, and then looking at the arc of their outcomes, measuring their resilience as it grows, and even measuring their hope. It's really a thing called hope science. And you can actually track how someone's hope increases, which leads to their healing. And so we'll keep you informed as we do all that. So certainly thank you very much. Yeah. Yes, Rashad.
And Adam, let me be clear for all of you who are watching and looking at the slide. The only reason why my mask is off is for the picture. I put it right back on.
Thank you.
Mr. Chair.
Thank you, Director Rosenberg, and thank you, Program Manager Singletary, for your leadership and everything that you all do. I'm gonna move through the committee just to see if there's any questions or comments that anyone would like to make with the great work that's going on over at Lifebridge. Seeing no questions, we'll go on to the next presenter, Executive Director Lydia Watts with ROAR.
Thank you so much, Chairman. And I just want to echo Joyce Lombardi's thanks to all of the senators and delegates, in particular the members of the Budget and Taxation, as well as House Appropriations, for your past support of the VIP legislation, as well as other areas of support that you have shown to many of the organizations and the issue areas that we all address. So I'm going to start with a very brief introduction of what the ROAR Center is. We're relatively new. ROAR stands for the Rebuild, Overcome, and Rise Center. Next slide, please. ROAR was started in January of 2019. We are a University of Maryland, Baltimore center, which means that we are a multidisciplinary center at the university. We're primarily focused or cited within the law school, but we are a multidisciplinary center that provides legal services, as well as what we refer to as supportive services, which is our therapeutic, as well as our case management services. And then we also have an RN who provides nurse care management services, which if you're not familiar with, I'll address that in a few minutes. We very intentionally define crime victim, the term crime victim, very broadly. Our mission is to provide these services to crime victims specifically in Baltimore City. What I mean by defining crime victim broadly is it's all the things that may come to mind, like domestic violence, sexual violence, child abuse, certainly gun violence, both survivors of homicide as well as survivors of non-fatal gunshots or other penetrative wounds. But it also includes folks that may be, usually for economic reasons, sort of forced to live in housing conditions where the property is being illegally rented, where there's environmental toxins, lead paint, mold, all of the things that we know have a very bad outcome for people's health, as well as folks that are impacted by other illegal environmental releases of toxins or other environmental crimes. So the crime can be committed by an individual, or it can be, by a landlord or a management company that's not taking care of their property, or somebody who has illegally dumped toxins into the environment. A police report does not need to have been filed. The reason I raise that, and this is, I think acutely true for the communities that you've heard about. Greg mentioned this in his introduction that certainly for gun violence survivors, but really for all of that type of victimization, particularly among communities of color, there's a very hesitancy or downright, really not wanting to involve the police. So we do not require a police report to be filed. We refer to that as being very low barrier, both in terms of defining crime victim broadly and not requiring a police report or a protection order or anything to sort of prove that someone's a victim. Their say-so is sufficient. We also don't have a time limit. It doesn't have to have been a victimization within the past 6 months. It can be at any point along the life cycle. As Adam Rosenberg was mentioning, polyvictimization is a very well-documented and well-researched phenomenon that folks that experience a trauma are much more likely to experience subsequent traumas over their life course. So the vast majority of folks that come to us have experienced multiple types of traumatization. Next slide, please. I already covered this. So we are in collaboration with all of the schools on campus. So we are able to avail ourselves of the expertise of all of the schools that are part of the University of Maryland, Baltimore, the professional schools. Next slide, please. We very intentionally reach out to folks that are the least likely to report to the criminal justice system, and they are also the most likely to be victimized. So it includes this list here, which I won't read aloud, but some of this is probably intuitive to many of you. that many of these folks that are in this list are very hesitant or unlikely to call the police, and yet, and not coincidentally, are also the most likely to be targeted for victimization. So we really work very closely with organizations across Baltimore City that specifically work with these populations, so that they are familiar with our services, and we get a large number of referrals from those organizations. Next slide, please. Next slide, please. So again, we serve survivors of all types of crime. About a third of the folks who come to us are survivors of homicide and gun violence. So it's family members of folks who have been killed as a result usually of gun violence, but also those who have survived. Next slide, please. So what is particularly unique is that we provide legal services. We are not criminal defense attorneys, though we do, as has been mentioned, there's a fair number of folks that experience gun violence that are criminally justice involved. For those folks who have, an outstanding warrant or something of that nature, we do assist them in getting connected to defense attorneys, but our services are civil legal services. So again, I won't read the list, but this is the types of legal services that we provide. And just to reiterate what Dr. Richardson said, housing by far and away is the biggest need for services, not only in terms of the legal services, but to find affordable and safe housing. Next slide, please. Our supportive services, this is the types of services that we provide through both our counseling. To answer a question that I saw in the chat, we do also provide counseling services to the family. Many of the gun violence survivors who come to us are living with mothers or aunts, grandmothers, girlfriends, and those people are also impacted, particularly if there's a fear of retaliatory shooting or any perception that the gun violence survivors cooperating with the police that would lead to a retaliatory shooting. And so oftentimes we're helping the whole family unit move. Next slide, please. I'll just quickly talk about the nurse care management services. This is a huge issue for our gun violence survivors that come to us. Most of our referrals come from Hopkins shock trauma, as well as University of Maryland's Medical Center shock trauma. Those are our two primary referral sources for the gun violence survivors. Many of these young men, primarily men, some women as well, they're discharged after X number of weeks or months in the hospital and are handed a whole stack of referrals for their follow-up care. And to be quite candid, they don't have that level of health literacy. Many of them never had health insurance prior to when they were enrolled, when they came into shock trauma. They don't really understand I don't really understand it, right? Like what your health insurance covers, what you have to go back to for a referral. Often they've missed a lot of those medical appointments. We've had we had one young man in particular, 3 months post-discharge, who had not changed his colostomy bag because he did not know that was something he needed to do. I see you, Joyce. Next slide. We do outreach and training. Next slide are a couple of examples. Next slide, please. These are the organizations that we collaborate with. Next slide, please. And this is just two examples of survivors we've helped. I won't, because since I'm out of time, but as you can see, each person, to echo what Rashad said, these are individuals. They are not numbers. They are not simply victims. Many of them, their lives have been very unraveled as a result of being shot, and they need very substantial follow-up assistance from all of our services. Next slide, please. And this is another example, and again, how we help the family members as well, and the way in which the legal case management, nurse care management, and counseling assist everybody. Next slide, please. The communities we serve, you may be familiar with this, are referred to as over-policed and underserved, and these are the ways in which that impacts them. Again, I know that there's an interest of some of the members of the General Assembly on this call of the social determinants of health. I am actually, I've been 24 years an attorney, and I have gone back to enroll to get an MPH at Hopkins. I'm a Bloomberg Fellow in the violence cohort because of this clear connection between those adverse childhood experiences, the other social determinants of health that that often not even often is a precursor, quite literally, to someone later being victimized by gun violence. In almost all situations, they have had a very complex history of trauma in their life, and they're really treated at that time of going into the police in a way that is not the compassion and real support that they need to not be back in the hospital within 5 years with another penetrative wound or behind the gun shooting somebody else. So we do work with BPD on those very actively. Many, of course, police officers responded to each one of these shootings, and many times, both for the family members of homicide as well as for those who survived the gun violence, there's a real need to hear from the detectives about what's happening with the investigation. So we do work very closely both with the homicide division as well as the advocates in the homicide division, as well as in the shootings within the Baltimore Police Department to try to apprehend the person who either committed the homicide or the shooting. Next slide, please. This is just my contact information. I'm at the end, so sorry for going over time, but I thank you all for your attendance this morning and for listening to our presentations.
Director Watts, I just want to say thank you for the presentation, and I'm just going to go through the committee, make sure that we don't have any hands raised. I'm now going through every screen just to make sure that there are no questions of the committee. And we are on the final presenter, Elizabeth Bannock.
Thank you. Thank you so much, Senator Mcrae. First, I just want to thank all the members of the Senate and the House today, including Budget and Taxation and House Appropriations, for your support of SB 708. And we hope you'll continue to support us by calling for an override of the veto. This is so important, not just because, as my colleagues today have shown, that this bill saves lives, but especially for those of you who are members of Budget and Taxation, you understand the importance of saving money now more than ever. And that is exactly what this bill does. Shootings in Maryland cost us money. Our partners at Giffords Law Center demonstrated that in 2016, the 1,652 shootings in Maryland cost us $7 million in healthcare, $154 million in law enforcement and criminal justice related expenses. And I think this is probably a large reason we saw the Baltimore Police Department testify in support of this bill. And I'll add that the Baltimore Police Department is also a member of our Maryland Violence Prevention Coalition. And $8 million to employers and lost income. This adds up to $1.3 billion a year in Maryland. Much of this cost is picked up by your constituents. 85% of gunshot victims have no insurance or receive publicly funded insurance. Additionally, law enforcement efforts are publicly funded. As a result, the gun violence cost in Maryland, it costs taxpayers $294 million a year. States that have invested in long-term and sustained support for evidence-based violence intervention programs have made progress. New York, which provided stable funding to such programs, has seen a 41% reduction in gun homicides since 2010. In 6 years, because of funds and oversight of violence intervention prevention programs like the ones you've heard about today, Connecticut has seen gun homicides fall by 16%. Massachusetts has seen gun homicide rates fall by 35%. And I'll just note that the ROCA model in Baltimore is, it's modeled after the ROCA model in Massachusetts. During that same 6-year period, the national gun homicide rate rose by 14%. In California, cities that have been supported by that state's grant program, CalVIP, have seen reductions in homicides 3 times greater than other areas. Since 2012, Oakland has cut its annual shootings and homicides by nearly half. In 2018, Oakland recorded its lowest number of homicides in almost 2 decades. This stands in direct contrast to many other major American cities that have seen an increase in gun violence after 2012. In our often gridlocked Washington, we have actually seen bipartisan support of a bill sponsored by our own Maryland Congressman Dutch Ruppersberger in HR 5855. The Bipartisan Break the Cycle of Violence Act funds programs much like the ones you've heard about today and passed the House, not only with support from Republicans and Democrats, but also from the FOP and the National Attorneys Association. And why did we see that bipartisan support? Because like you, even in Washington, leaders can agree on saving money. Before the veto, Maryland was poised to be a leader in these violence prevention efforts. There's no reason we can't see the same successes as California, Massachusetts, Connecticut, and New York. We have the practitioners and passion to get this work done, as you've seen from our speakers earlier today. We just need the oversight and money to make it a reality. I want to thank all the members of the Maryland Violence Prevention Coalition for speaking today, Joyce Lombardi for working so hard to pull us all together. And again, I want to thank you, Senator Mcrae, for setting up this briefing, and thank you to Senator Miller, Senator Edwards, Senator Peters, Senator Gazone, Delegate McKay, Delegate Proctor, Deputy Majority Leader Haynes, and Ms. Landry and the B&T staff for your time and hard work. And I'm sure if you guys have any questions, we have a little bit of time, I believe.
You know what? I did have a question for Executive Director Rosenberg that I missed during the Center for Hope's presentation. You talked about DSS and you talked about the police being partners in that space. Are these going to be satellite offices where there are agreements that were that are made in some capacity, and what respective district? I know we got 9 police districts. I believe you may be in the Western or
Thanks, Senator. The new center is located in Northwest Baltimore, in the Northwest District. We've had the several co-located police units with us for the last 20 some years, child abuse, family violence, and missing persons who investigate those cases and those crimes there. That co-location we're anticipating comes with us to the new building. We still have to work out the details with the police department and GSA, obviously, but it's within our plan that that will be located there. So it's not a satellite or a substation, but a location for specialty units to be there, so that literally when cases occur, not just child abuse, but domestic violence or elder abuse, it's a one-stop shop. So that teams don't have to go to multiple locations, and more importantly, victims and caregivers don't have to go to multiple locations to be able to get answers. Everyone at that building will be helping and facilitating those cases there. Folks from child abuse, domestic violence, family crimes, missing persons, all who work with human trafficking victims, domestic violence victims, elder abuse victims. And then we also anticipate working closely with the Department of Social Services to be able to place specialty teams from Child Protective Services as well as Adult Protective Services. So again, it's all done in collaboration and coordination there. And I think that's the model of what a lot of this is building those multidisciplinary approaches so we can let people do what they do best, and that in the end, a police officer doesn't have to do childcare. We can deal with that. A staff member from the Department of Social Services doesn't have to provide therapy. We can make the therapy happen on site or make the recommendations there.
Thank you, Director Rosenberg. I see that my chairman has a question. Chairman Gazone.
Thank you, Chairman Mcrae, and thank you for putting this together. This has been really great. I really appreciate this. This is really important stuff, and I'm reminded of my first years in the Assembly, which were about 14 years ago. And back then, people were barely even thinking or talking words like evidence-based practices, holistic approaches to dealing with problems. And I've actually been very heartened over the last number of years that that's what we keep talking about now, and that's what we should be talking about now. And I am just really gratified to have so many folks coming at it from a number of different angles working on this. And all I can say is to the degree that I hope the committee can do as much as it possibly can to support you all in what you're doing, because as I said, I think you're right on target, and very impressive. So thank you all very much.
Thank you, Mr. Chair. I just wanted to swing to my counterpart in the House, Delegate Keith Haynes, Chairman Keith Haynes, just to see if he had any comments or closing remarks for the committee. Looked like he might not have joined, but he was trying to join by phone. Okay, there he goes.
Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Okay, great. Slight technical difficulty on this end, but first of all, just in the interest of time, Chairman Mcrae, thank you so much for including the House counterpart of Public Safety, the Public Safety Committee, and also thank all the participants and coordinators for setting this particular briefing up. And also want to be sure to mention the members, House members on public safety who have attended as well. One of the things I just want to indicate is that how we have over the past few years, and I think Chairman Gazone probably put it best, is that we have really switched the paradigm of the perception of how we address issues from being reactive to being proactive and putting the resources where the emphasis really needs to be, and that's up front, so that we can provide those resources, the funding, the support, and addressing systemic violence before it occurs, as opposed to trying to incarcerate ourselves out or confine ourselves out of situations. And so from that standpoint, I know that public safety on the House side for several years since I've been chair and before, we have looked at incrementally how we can make that happen. And I'm so glad to see that it has, on both the House and Senate side, the perception has moved towards addressing these issues proactively and giving the resources where they need to be done. And so with that, I just want to say thank you, Chairman Mcrae, and thank you to my Vice Chair, Proctor, and all House members on public safety for attending. Thank you.
Thank you, Mr. Chair. As we close out, I just want to say thank you for all of our Senate members that once again played a part in this role in this briefing. Senator Edwards and Senator Peters, the committee members on PSTE, and each and every one of you who all presented. I thank you for not just presenting today, but I thank you for your leadership on this critical issue. I cannot reiterate it enough that you have not only had this chamber's support in reference to the legislation that you care about and that you've put forward, but I'm sure that after this constructive dialogue that you will continue to have our support moving forward. So I just want to say thank you again for you all's leadership, and thank you again for this opportunity for this briefing, and this hearing is adjourned. Thank you.
Thank you very much.
Yeah.